Don't worry, folks. I got my hiking boots on, so I can't take off my pants. Jens will explain that one to you later. You had to be there. I just wanted to, one of the great joys of my professional life in myeloma is I've gotten to know a lot of really wonderful people. I met Jens the first time, I believe it was 2006. And it was truly friendship at first sight because we addressed each other by our first names pretty much immediately, and that, if you know German, is not common amongst adults. And we have been, I've considered him just one of the really fabulous persons in myeloma. He is just a real mensch. And as you will see, when I met him in Heidelberg, and then when he came over to Roswell Park in Buffalo, I immediately called him up and said, "Oh, I'm so happy," and I got him to speak at one of my first roundtables right when he was here. So he's been a good friend. We met him, I introduced him to Jenny while he was still in Heidelberg. He did a radio show, and he's been a friend of the myeloma crowd and now the Health Tree Foundation pretty much close to since our inception, and I'm so happy he's here. And you're really going to like Jens. So, Jens?
Thank you so much, Greg. Should I use this mic or the other one? Okay. Hi, everyone. Thank you so much for the kind introduction. Thank you so much for the invitation. This is awesome. I went up because I'm a little bit jet lagged, even those two hours from Buffalo is too much for me. So I got up very early, went up the mountain, and it's so beautiful here. I'm really feel very blessed to be here. I already got to know amazing people and could talk to you guys, and this is just, I'm really happy to be here. I would like to talk about one of the things that have become very important to me in my life as a myeloma doctor. And it was triggered by my patients. I started treating myeloma. Actually, my myeloma research started in 1999. Yes, I look a little bit younger. People say I stay out of the sun, but that's a different topic. And very early when we started to get better outcomes in our patients, they started to ask me, initially when I started, we had melphalan, prednisone, and thalidomide. And thalidomide was the new fancy drug. So at that time, we talked about how can we keep our patients alive. Now, patients live longer. I don't have to tell you about that, but they ask me, how can I get back to things that I have done before? And for me personally, and for a lot of my patients, physical activity, exercise, workout, however you would like to call it, is very important and is an important part of our lives. And that's why I became interested. It was literally triggered by my patients asking me, what can I do? And then, as some of you might know, imaging is something that I started back in the late 1990s. I'm still, I'm old. I started that, and imaging is something that I'm very interested in, and we found that obviously patients with myeloma have osteolytic lesions and physical activity. Funny enough, my feeling is that all my patients ask me, can I either go mountain biking, downhill skiing, or tennis? And I said, or golf. And my orthopedist that I worked with said, don't twist and turn and bend. And that's exactly what they're doing. So we said, we need to figure out what's going on there. And so we started, I wrote my first proposal about physical activity in myeloma in 2011. And I had to come to this beautiful country to get it funded. Literally, that was one of the reasons why my wife and I came to the US, because we hoped that we get this up and running, and now we finally have funding and can do research on physical activity. My wife would have liked to be here, but unfortunately the only time her parents and two of her sisters could come to visit us is exactly now. So she has to be in Buffalo and is taking care of her family, and I will leave early tomorrow morning and do that too. But I'm really happy to be here and talk about physical activity. A lot of talking to get this started. The topics I would like to talk about is, would you mind putting the slides here too so that I don't have to bend over, if that's okay. what are we talking about? And I already started that, what's relevant, what have we done so far, what have we done with HealthTree, what have we done with Roswell, and I have to apologize. I had really nice slides about our data from HealthTree, where we send out questionnaires about physical activity, and then I remembered, oops, ASH, the hematology meeting in New Orleans this year. New Orleans, they say I cannot present it before it's presented there because I sent an abstract there together with Jenny, together with Nathan, and I cannot present the actual data, but I would like to talk with you about the results that we have and also how you would like to interpret. So I would like, at the end of this talk, I would like to have some interaction to figure out how you feel about the things that we found. And also what we are planning to do, what we build upon, what we have learned so far. And then I was asked to tell you some simple steps, what you can do and what you can tell your people that you are taking care of, what they can do. And then also what the impact is, and especially for our research, but also for a lot of other research. And I think Urvi will also talk about this later, what HealthTree can help us to accomplish in research in myeloma. So the challenge, as I said, myeloma, bone disease, right? That's not a surprise to you. I don't have to tell you a lot about that, but that's obviously a challenge if we talk about physical activity. It's caused, and you all know that, I guess, by an imbalance of the bone-eating cells, the osteoclasts, and the bone-building cells, the osteoblasts. We all have them. If we're healthy or sick, we have osteoclasts and osteoblasts, and our bone is continuously turned over. And in myeloma, the bone-eating cells, the osteoclasts, are overactivated. And so we see in patients these holes in the bones, these osteolytic lesions. And that's obviously a problem if we talk about physical activity. It's a very important topic, and I have the privilege to be the co-chair for the imaging and bone group in the International Myeloma Working Group. And we talk a lot about that, even though we know that for decades now that this is going on, we still don't have a great solution for it, A, to prevent it, and B, to really treat it very well. Thank you so much, I got it here. So there's an interaction between the myeloma cells and the bone-eating cells and also the bone-building cells. So the myeloma cells block the bone-building cells, they overactivate the bone-eating cells, the osteoclasts. But then also the osteoclasts get substances like nutrients out of the bone to feed the myeloma cells. So this is a vicious circle, and we have to do everything we can to stop this and to stop it at every angle. We will treat the disease, obviously, so we will cut it at that end. But we also have to treat the bone disease itself. So the clinical significance, and this is known for a long time, actually the data is from 15 years ago and longer, that almost all myeloma patients get bone disease at one point in their life. We are now treating patients earlier. I mean, at that time we didn't treat patients with smoldering myeloma, for example, and you know that we start doing that. But at that time, we saw in almost every myeloma patient that they have osteolytic lesion. We know that more bone disease is worse. So for many, many reasons, like people are not as active, people have other problems. Obviously, pain is a huge factor. And so these are very important parts of the life of a myeloma patient, independent of the good treatment that we have. If the bone disease is there, it is a challenge for the rest of the life of the patient. And pain, obviously, fractures. Hypercalcemia is related to that. This overactivation of the osteoclasts gets the calcium out of the bones into the blood. Fortunately, we usually get that under control fairly quickly, but still it's a challenge that we have to deal with. And the peak of the bone disease is actually at diagnosis. Later on, that's the good thing. When we know that it is there, we have treatments like bisphosphonates, we have treatments like rank ligand inhibitors, denosumab, where we can treat and prevent to a certain degree further worsening. But oftentimes we just don't know before the diagnosis is done that the patient has myeloma, obviously. The goals are obviously we want to make it better. When I started treating myeloma, and I say this sentence more and more, especially to my students and my fellows, when I started treating myeloma, I was told osteolytic lesion will never disappear. And I believed that, and for a long time, and as I said, imaging is kind of my shtick, I believed that, and we didn't see any change. Now we do CTs instead of X-ray, and CT is much more sensitive. And you can see, I hope you can see, on the, I know that's going back. On the left side, you see the osteolytic lesion. That's a vertebral body, right? Kind of cut through the vertebral body with the CT. And on the right side, you see that the body starts kind of rebuilding bone. And that's something, I don't know which patients do that. We are looking into that. I actually have a medical student looking into a lot of PET CTs before and after treatment to see what are the characteristics of patients and what can we do to improve this bone rebuilding. And this is, again, this has to be our goal, that we actually even make the bones better. This is not a promise, but it's something that we are working on. And then there's an interaction with the immune system. As you know, myeloma patients have a high risk to get infections. That's why a lot of us here wear masks, and I also wear masks to protect my patients. And there is a lot of stuff going on, and it's a fairly new area of research because we now have the tools to diagnose the immune function, and there are like dendritic cells, there are NK cells. I don't want to go into details, but the myeloma cells kind of suppress the immune system, and other cancers do that too, right? Because usually when a cancer cell appears in the body, the immune system says, oh, that's wrong, and kills it. But if cancer develops, obviously that went wrong, right? Because the immune system could not catch that. And that's also the basis for a lot of our treatments. We want to re-educate our immune system to fight the cancer cells. And in myeloma, that's obviously with the antibodies, with the bispecifics, the CAR T cells. That is something that we're doing more and more. And that's something where I personally feel we have to also start to intervene in a way that we improve the healthy part of the immune system that has been compromised by myeloma. And to prove, there's a lot in the literature showing that there are a lot of suppressive factors going on in the immune system of a myeloma patient. Another factor when I think about physical activity is obesity, and that's unfortunately a topic that we have to deal with. And you can see here that the mortality of patients with myeloma and also other cancers, I actually cut that out of a long, long list of cancers. Being obese is just worse for a patient with cancer. The mortality is higher if a patient is obese for several reasons. Obviously, there are cardiocirculatory things going on. There are other things like diabetes going on, and that's obviously not good, especially not in patients who get a lot of dexamethasone, which is actually another topic that we are working on to reduce the dose of dexamethasone. Talking about bone strength, I am still a little bit less, but still very careful when my patients ask me, what can I do? And again, I said, why do myeloma patients not want to go Nordic walking? Why do they not want to go, I don't know, things that are less impactful to their skeleton? They want to play golf, they want to do downhill skiing and so on. Even in Buffalo, it's flat there and they still want to go downhill skiing, but that's a different topic. And we know, of course, that inactivity and immobility is bad for our bones. And we know that from the astronauts, right? When they go to the space station, they come back, and you all have seen the pictures when they come in a wheelchair. I mean, those guys, they are in the best shape that anyone can ever be when they go up there and they come down and have osteoporosis. So obviously, if there's no impact, if there's no movement, no weight on our skeleton, we lose. But if you don't use it, we lose it, right? And that's something why they do weightlifting. Well, in space, it's not difficult to weightlifting, so they have very specific machines to kind of simulate the gravity to kind of to put pressure on their bones. So on the one hand, I say bone fractures is a risk. We should not let our patients lift heavy. On the other hand, I say if they don't do anything, that's also bad, right? So we have to learn what is good for a patient and what will help them. It's also important, how do you put pressure on your skeleton? So there are, and I'm not the expert for that, but I spoke with orthopedists and looked into the literature. And for example, you can see here running and I think control, CON is the control group. Running seems to be more effective for the bone weight, in this bone density in this case, than swimming, because swimming, again, takes away gravity, right? On the one hand, we don't want to kind of stress too much, but on the other hand, we need some impact or we need some trigger for the bones to resist, right? And that's why I think resistance training is an important part. I talked about obesity. There, aerobic training is an important part, and I see that you have different, Lindley is doing different exercises with you. That's exactly what we want to do. So we have to do combinations of both to put some pressure on the skeleton, but not too much, and that's actually where we want to go. This is unfortunately a little bit scary picture, but you see where this blue arrow is, this one patient. One is this transversal, and there's a radiologist in the room, so I'm getting a little bit more nervous now. And you can see this sagittal, where you can see that the bone is destroyed, and we can obviously not let this patient lift heavy, because that would make the pressure too much. So I have not given you a lot of answers, but I kind of want to paint a picture of what's going on when we talk about exercise, activity, physical activity, and research in this area in myeloma. Here's some data on all hematologic diseases, including multiple myeloma, how exercise has an effect on the immune system. There's really good data, and this is kind of just an image, but there are certain cells that are stimulated by us working out. Right, and there is, for example, T cells that are there are a whole bunch of T cells, but certain T cells are kind of, they're woken up by exercise, right? Senescent is kind of, they're sleepy, and we improve them, and we have first data, and again, because of ASH, I cannot tell you the actual results, but I can say it works. So there's an effect of exercise on T cells, on immune cells. NK cells, there's a study, and that's already published, so I can talk about it, where they measured healthy people. They took blood before they walked 10 flights of stairs, and then they took blood again, and they saw that the NK cells went up. Since then, I walk to the 8th floor of our building in the morning, and when I meet people, I encourage them to do the same. I don't tell them that when they measure the blood 10 minutes later, the NK cells were gone again, but it is a short boost of immunity, and we have to learn more about that. And there's a lot of research going into that. And then macrophages, monocytes, these cells are kind of eating up cancer cells, eating up germs, and they can also be stimulated. The right ones can be stimulated, and there are also bad ones that stimulate kind of unnecessary inflammation, and this can also be regulated to a certain degree by exercise. What we did is we sent to HealthTree, we sent a few questionnaires. Obviously, pain is an important influencing factor if we talk about activity, right? So we asked patients, what's your pain score? We asked, what's your fatigue score, right? Because I don't have to tell you that fatigue is an important factor. We oftentimes kind of, as doctors and as researchers, we try to ignore that a little bit because there's not so much we can do, right? The only data, to my knowledge, is actually physical activity, being active, which is very counterintuitive. And I see the faces of my patients in front of me when I tell them, they tell me I'm fatigued, and I tell them, yeah, be more active, and say, I just want to be on my sofa and sleep, right? I understand. But I try that myself. I'm a physician, so I work a lot. I'm the only myeloma doctor, so I'm on call 24/7. So I know a little bit about fatigue, nothing compared to what a patient goes through. But I also know when I push through and I do my exercise, I feel better afterwards. And that's something I want to encourage you. It is a huge lift to do that, and it's pun intended. We have to break through this fatigue to then go on and kind of experience the improvement of the fatigue. Distress. We did an analysis, and I have to, again, this is just the tools that we used, and I cannot talk about the results, but there seems to be a connection, and that's where I want to be interactive. There seems to be a connection between people with distress, like worrying or not being able to do certain things, and exercise. So we asked patients, how much exercise do you do? And I think that's the next slide, actually. Yeah, we asked them, how many hours per week? And we had categories like 0 to 2, 2 to 4, 4 to 6, and over 6 hours per week of physical activity. And we let the patients define themselves. And we asked, how much did you do before your diagnosis, in the 5 years before? And some of you might have contributed to that. How much do you do now? And how much do you want to do? And we have already published, we have done the same exact questions we have done in a German study in Heidelberg, where I worked before, where I met Greg. And it's exactly the same. Same there, same here. patients have done more before, at least they claim they have done more before, but I believe them. There's kind of a dip, and then they want to do more, right? So this message is loud and clear. Patients want to do more than they do right now. Some even want to go to a higher level than before. Because as you know, a life event like being diagnosed with myeloma, that's a pretty, it's waking you up, right? You think more about your health, you think more about what can you do to prevent things, and to get better, right? And so patients actually want to do more than they do right now, and they oftentimes even want to do more than they did before, right? So what we got back was over 700 responses in a pretty short period of time, and thank you so much, Nathan, for all your help. This was really awesome. We got in a few months, we got over 700 responses. Mostly myeloma patients. I think that's reflective of what HealthTree CureHub has. Some smoldering, some MGUS, and also very interesting to compare the different stages. We have published already, again, same questions in a German study where we found that MGUS and smoldering myeloma patients have the same level of distress, anxiety, depression as a myeloma patient, sometimes even more. And we have questions where we ask, for example, how can you talk with your family, your caregivers about your situation? And MGUS and smoldering patients, I'm not sure how much you have that in your kind of area of influence, but they oftentimes suffer more because with the myeloma patients, as sad as it is, everyone understands what cancer means, but what's MGUS, right? What's smoldering myeloma? And these people oftentimes suffer because no one understands what they go through. Every time when they come, and I know that because my patients tell me, every time they come to me, they say, the week before I cannot sleep because I don't know what my numbers are, right? Do I have myeloma now or do I not have myeloma now? So that's also very stressful, and that's also something where we want to see if improving quality of life, it might not distract from the fact, but maybe it helps a little bit. So future projects that we are planning, we want to do lifestyle interventions, and we are also collaborating and talking a lot with Dr. Shah, because I think things like nutrition, things like exercise, and other things we try to leverage to improve immune markers, to improve bone markers, and so on. And so that's the objective. I just copied that from our protocol. We have a protocol now up and running, and we already have a lot of requests from patients who heard about our study. We have 3 cohorts. One cohort is only for newly diagnosed patients. We have a really strong immunology group at Roswell Park, and Dr. Repasky, awesome colleague, she is using beta blockers to lower stress, not the stress level, not the stress that you feel, but the effects that stress has on your body. You know, beta blockers, they're blocking kind of stress hormones, and that's what she's using to see the impact on the immune system, because we know that certain stress, even stress nerves, like the sympathetic nerves, go into the bone marrow. So there is a connection between stress and myeloma, obviously. And we try to tackle that with this one cohort. One cohort is exercise, 6 months of exercise twice a week virtually. So you can do it from wherever in the country, and you can work out there. You have to come to us for the blood draws, obviously, but other than that, it can be done from home. And we have learned that during COVID, because we had an in-person study that we started about half a year before COVID hit. And it was a challenge for patients to come in, obviously, and a lot of patients were scared and said, I will not come anymore just because I want to limit my exposure. And then the third is intermittent fasting, because I didn't want to interfere with what Dr. Shah is doing. She's feeding you, I'm starving you. So, but my wife and I have tried it ourselves. It's actually not that bad. So we have 16 hours of fasting and 8 hours of eating, and it is. We, for religious reasons, we are Christians, so during Lent we also try to fast every once in a while. But intermittent fasting is actually not that bad. I personally felt, and I love food, and the people on my table saw that I eat a lot. So yeah, and we want to see what's the effect on the immune system, what's the effect on bones, what's the effect on quality of life, on fatigue. What can we do with interventions that have no side effects, other than you might lose a few pounds if you do work out more and if you have more, if you do intermittent fasting. Yeah, and yeah, we want, I mean, response to therapy, we'll see, right? That's very ambitious, but we just check it. We have a fairly large number, and then we will compare. It's not really like a randomized study where you can compare A with B, but we want to see what are the effects of the different interventions. Inclusion criteria, it's fairly straightforward. We don't want to enroll anyone who might be harmed by this, right? People who are already cachectic and cannot like eat at all, I don't want them to fast. I want them to eat what they can. And same if there are acute bone issues, then I don't want them to work out. But we have a really good neurosurgery team, a very good radiology team. They're helping us to identify how we can enroll patients. And then so general recommendations, what you can do tomorrow or maybe later today after you left. Most people know about Fitbit or Actigraph or Apple Watch or whatever. I have no interaction with any of these companies. I personally have a Fitbit because we give that to our patients because it's fairly cheap. And there's the magic 10,000 steps, right? And they are basically just a marketing gag. There's no data for 10,000 steps, but there is data for 8,500 steps. So there's a study where they looked how many steps per day have actually an effect. It was the women's health study, a large study, and they looked how many steps are really helping. And you can see 8,500, that's what I've set on my Fitbit now, because I never got the 10,000. Not never, but not often, because I sit on my butt too long. But you can see the effect kind of levels out. If you do 8,500 steps plus, then you have a positive effect on your health. And that's doable. Even I can do it, and I have I'm a doctor. I sit a lot in my office. Other things are, for example, the 8,500 steps in this study. They found that triglycerides are getting better, so our blood fats are getting better, independent of myeloma, but it seems to be healthy to do that. And you can also see, sorry, I'm not sure where to point this, but other things, for example, if you sit too long, that's another thing that actually my wife taught me. She did a personal trainer course and is now going to college to become an exercise scientist. And in her late 40s, but let's not talk about that. That will be challenging for me too. But so she found an article where they found that if you sit 8 hours per day, if you work out the next day, it's basically useless, which was very disappointing to me because I sit a lot. So what I do now, again, not Fitbit, whatever tracker you have, or even just a watch that tells you once an hour, get up, they actually have the 4-second sprint. 4 seconds, that's nothing, right? You have to get up, walk a little bit, and then you have the effect of the workout of the next day. I was shocked when I learned that. Now I do it, and it is really cool. I mean, just getting up for a few seconds, there's kind of a trigger for me to do 250 steps, right? And if that, see, exactly. I love it. You're listening to what I'm talking about. It's actually true, right? And that's also why I'm pacing here, right? I get my steps in. And no, I learned that's good. That kind of keeps people focused. No, but it's really like short bouts of getting up, walking around, and then sitting again is much more effective than you don't have to that's something that everyone can do, right? Independent of your bone disease, independent of what's happening. That I skipped. I didn't go into detail there. So what for you? What can Health Tree do for you if you participate in Health Tree? And I guess I'm talking to the choir here, but it will obviously help us to develop better therapies, better interventions, for example, lifestyle. No offense to the colleagues from pharma in the room. A pharma company has no real interest in just improving quality of life for the sake of improving quality of life because they have stakeholders. I don't blame them, don't get me wrong. They have stakeholders that they have to report to, but we as a community can do things with, for example, with Health Tree. You will, through Health Tree, as you know, you get access to the newest information. You have a very close supervision of what's going on, right? You can connect with people, you can learn about your disease, and you can put that into practice. And you will also have kind of personal attention by more people because you're interacting. As I said, I'm on call. I'm sorry, they are paging and calling me. No, I cannot talk now. Sorry. Yeah, and then Sorry. Yeah, you can learn more about yourself, about your disease, and you can also reduce cost of treatment because we will learn more about other things that we can do to improve the efficacy. For our research, it's really amazing to have access to HealthTree. We can advance the field by itself. We can generate new hypotheses for training, and we have access to a huge number of patients. Roswell Park is in Buffalo, New York. Buffalo has 250,000 inhabitants. I don't have access to such numbers, right? And I'm there for these people, but I can learn from all of you and from the people of the whole country. And so my recommendations, before you lift heavy weights, please talk to your doctor first, preferably even an orthopedist. Set achievable goals, because if you plan to run up the hill, that might not happen, but do something that you can do, because if you are too disappointed after you do it, then you might not do it again. So that's something important. Get your steps in, 8,500. It can be a little bit more, no worries. You will not hurt yourself if it's a bit more. The general recommendations, if being moderately active for 150 to 300 minutes per week, it's not that much. I also think it's challenging, but it's doable. Don't sit for too long. Get up, move around a little bit, and then sit down again if you have to. And combine aerobic with resistance training, because both have their benefits. The aerobic training helps our cardiovascular system. The resistance training helps our bones. And register at HealthTree, obviously. That's my next talk. One thing I wanted to briefly, I have 30 seconds left. One thing I wanted to ask you, just yell back at me or hands. We found that there's a correlation between being physically active and having less fatigue. Now the problem is, what is the hen and what is the egg? Are people who have less fatigue more active because it's easier for them? Same with depression. We have seen there's a connection between depression and being physically active. Is it because people who are depressed are less physically active just because of the depression? Or do you think that physical activity helps overcome depression? We try to address that in our prospective trial because we measure all these things before and after. So we will see if patients change from before to after, right? We have a pilot study with about 20 patients, and that will be presented at ASH as well. But what's your feeling? What is hen and what is egg? Being more active helps, or having less problems helps to be more active? Who thinks it's more that being more active actually helps fatigue, depression, anxiety? Okay, good. Support that. Who thinks it's the opposite? And be honest, it's not, yeah. And I think there's definitely a fact. And I think it's not black or white, right? But I think we have to learn where we can help with kind of taking care of things. You had a suggestion, I think, in the back? Not, okay, good.
I think there's, like a bell curve.
Yeah.
And, the people who are somewhat fatigued, somewhat depressed can still have the motivation to, do the exercise. Yeah. And to, push themselves through it, and then I think that helps them. Yeah. But you have the people at the other end who simply don't have the energy to make that effort. Yeah, I agree. Yeah. Anyone else? Or any questions to what I've talked about? I have my second talk will be a little bit shorter, so if we run over now, I will make it up later.
Well, I just noticed that during because I did tandem transplants up front, and I was so fatigued. But I noticed that, and I talked to several people about this, that if they, some people said, I made them put a bike in my room during transplant, so I would force myself. And you really had to force yourself, even though you didn't feel like it, and it helped. Like, okay, today my goal is to walk to the mailbox and back. And tomorrow I'm going to try to walk a few feet further and then come back. So even though you don't feel like it, I don't know, it's just so important to just force yourself to do it, because you do feel better after you're done.
And good that you mentioned transplant. There's actually much more data for transplant, the beneficial effects of exercise during and before and after transplant. Yeah.
Or your spouse can force you.
That also helps, yes.
What's that?
Or friends or family.
No, you're forcing me. That's not true. No.
Is that why you have a brace? Or
So I can speak for me. When I was diagnosed in 2013, my doctors told me, they thought I was a gymnast when I came into the emergency room because I worked out a lot, I ran a lot. But they told me I could no longer work out or exercise or do anything for like 3 years because I had a vertebroplasty, a kyphoplasty, and all that. So I was very depressed. But once they gave me that go-ahead, Tony, you can work out, but they looked at me and said, we know you work out a little differently, don't overdo it. So when I started back, it was like game on. They said I will never work in this industry again. My body will never be the same. My posture wouldn't be the same. And here I am today, and my doctors are like, well, you proved us wrong. So physical activity is absolutely very important.
Yeah. Thank you so much.
Is there time for more? Okay, there's some over here.
I was just going to say about exercise, I believe that success or defeat starts in the mind. And also it depends on, we think about exercise, you think about running, skiing, those kind of things. But there are multiplicity types of ways to exercise, So when you're talking to people about exercise, to try different things. I happen to work with a clientele of geriatric patients a lot. Of course, they're not going to be doing a whole lot of running, but you find different ways of doing things. Like you said, arthritic patients, I always should tell them, don't sit for 15 minutes. 15 minutes, get up, and then sit back down if you don't want to walk, and just do that all day. You can do all kinds of things just laying on the floor. It's just a lot of things to do. And there's so many things out there now that, Pilates modified, yoga modified, praise moves, what I do, which is kind of like yoga, but it's done to songs of faith. It's just so many things. So if you have someone that's working with you that has imagination, there are ways to do it.
That's what we are also trying, and I talked a lot with my wife, who is the exercise trainer doing the study. It's, as you said, exactly, it's so easy to adjust and use a lower weight, use body weight, use reduced body weight. We have the technology, right, to do something with our body weight. That's not the whole body weight, right?
First, I'll second what Tony said. My experience was exactly the same, although I didn't listen to my doctor as long as he did. My question for you is, you mentioned the role of bisphosphonates in treating the bone disease. As we all know, I think can be some pretty significant side effects from that. I had a little bit of ONJ myself. Are there any other treatments that we're developing to help with the recovery from the bone problems that don't have those side effects?
Yeah, unfortunately, we were so excited when denosumab came out and thought, yay, finally something that doesn't cause ONJ. Well, it does cause ONJ. So there were a few other things, and patients have asked me about that as well. To my knowledge, there's no scientific benefit that has been shown in any other interventions, for example, that come from osteoporosis. Unfortunately not. Obviously, vitamin D and calcium, depending where you live, definitely. In Buffalo, New York, vitamin D is an important part. But it's nothing that's really as good as the bisphosphonates. And be very careful with obviously with ONJ, with dental interference. And I always tell my patients 1 month before, 3 months after, hold your bisphosphonates or your denosumab. To my knowledge, there's nothing new.
We're going to move on, but there is a question and answer session later. We will get to you. So we're just going to move on and then...
Sorry about that.
Oh, it's okay.
That was excellent, excellent. And as Audrey mentioned, we do have a Q&A section if you see on your agenda. So we will have plenty of time for questions today for all of our presenters. And Dr. Hillengass, that was excellent information, and he mentioned his wife, Michelle, who's helping him in this study, and she so wanted to be here today, as he mentioned, and she has contributed. She's been working with Lindley, and they've created a fitness handout that Lindley will be sharing later today, and we were so grateful for her input on that. Dr. Hillengass and Dr. Shaw have both been supporters of the COACH program and of the foundation with the studies they're running, and I encourage you to look at that and to participate. They've presented at our semi-annual calls, and many of you maybe have heard them speak, and many of you, from hearing them speak on our calls, we're so excited to meet them in person today, and I'm so excited to have them here. And